So, a 59-year-old man is diagnosed with atrial fibrillation. What would you advise him about the risk of warfarin and possible drug interactions? So, firstly, I would tell him about warfarin, that it is a vitamin K dependent, it inhibits vitamin K dependent coagulation factors 2, 7, 9, and 10, and it also inhibits the production of anticoagulant protein CNS, and that's why he needs to be bridged with heparin for the first 5 days when he's starting warfarin. It works on the intrinsic coagulation pathway, and that's why we need to measure his INR. For him, there is a benefit because it helps prevent stroke or systemic embolism in his non-valvular atrial fibrillation, and we want an INR of 2 to 3. It's also very useful for patients with a previous myocardial infarct who are at an increased embolic risk, patients who have prosthetic heart valves who are also at a great thromboembolic risk, and so the INR actually needs to be higher at 2.5 to 3.5, and for the prevention or treatment of venous thromboembolism. So my primary aim is to determine whether this gentleman is suitable for warfarin by balancing out his stroke versus his thrombosis versus his bleeding risk, and counsel him appropriately regarding the risk and drug interactions of warfarin. So to do this, I would need to take a thorough medical history. In terms of my history, I would want to make sure that he has the correct indications in order to have warfarin. So he does have atrial fibrillation. However, I would need to assess him in terms of the CHADS-VAD score proposed by the European School of Cardiology to determine whether aspirin is required, warfarin is required, or if he doesn't even need any kind of anticoagulation. I would also like to assess for any contraindications for warfarin, so his risk of bleeding by using the HAS-BLED score. And a score of 3 or more indicates the increased bleeding risk. If he has alcoholism, severe active bleeding like a peptic ulcer, severe hepatic disease, or severe thrombocytopenia, I wouldn't give him any warfarin. For past medical history, it's very important to see whether he has any other contraindications to warfarin, whether he has any previous strokes, and any physiological states that increase warfarin, so liver disease, high metabolic states such as infection, fever, and thyrotoxicosis, and decreased warfarin, such as hypothyroidism and pregnancy. In terms of, I would also like to ask about any medications and allergies which he may be on, and psychosocial, so his living arrangements, whether he lives rurally or in the city, and whether he's able to cope with regular testing. And if he's not able to cope with regular testing, perhaps a NOAC is more suitable for this patient, such as apixaban, dabigatran, rivaroxaban. So this is the CHADS-VAD score. C stands for congestive heart failure, H is for hypertension, A2 is for an age greater than 75 years and they get 2 points. D is diabetes mellitus, type 1 or type 2. Stroke is 2 scores. Vascular disease, age greater than 65 or more, which is just 1 point, and sex category, so they're an increased risk of stroke if they're female. So if he has a score of 0, then they have no aspirin or therapy is recommended. If he has a score of 1, then aspirin or anticoagulation is preferred, and if he has 2 or more, then oral anticoagulation with warfarin or NOAC is recommended. So because this gentleman, his age is above 65 and he has atrial is above 65, he has 1 point. And so we need to take a history to make sure he doesn't have any of these other points. Otherwise, if he does, then he would definitely need warfarin. I would also like to do a HAS-BLED score to identify risk factors for bleeding in patients with atrial fibrillation. So if he has hypertension above 160 millimeters mercury, I'm very worried about intracranial hemorrhages. If he has abnormal renal or liver function, if he has a history of stroke, history of bleeding or a predisposition to bleeding, if he has labile INRs, if he's elderly, greater than 65 years, or if he's on any drugs such as antiplatelet agents, NSAIDs, or drinks more than 8 units of alcohol per week. So in terms of a physical examination, I'd look at his vitals just to assess his heart rate and rhythm because he has atrial fibrillation, which I would suspect him to have an irregular rhythm. I'd also like to do a cardiac exam looking for arrhythmia as well as signs for heart failure, which may have precipitated atrial fibrillation. So if he has left heart failure, I would do a respiratory exam, look for any inspiratory crackles or crepitations or cardiac wheeze. If he has right cardiac failure, I'll look for right chest heave, whether he has an elevated jugular venous pressure and peripheral edema. I'd also like to do a neurological assessment of both the cranial nerves, upper limbs and lower limbs, in order to see whether he has any neurological deficits, which may suggest he previously had a stroke, and this would be used for the CHAD-VASc as well as the HAS-BED score. In terms of counselling for warfarin, this can be summarized in the mnemonic known as Warfarin. So W stands for what's your warfarin, A stands for alcohol and other drugs, R is risk of bleeding, F stands for food, A stands for adverse reactions, and RIN stands for regular INR testing. So I would counsel him to watch his warfarin, that he needs to use the same brand, whether that be Coumadin or Maravan, every day, because they have different bioavailabilities. For him to carry a treatment card or some kind of necklace or wristband that says he is on warfarin, and an INR anticoagulation book just to follow his INRs. In terms of alcohol and other drugs, you want to assess whether he has any inducers or inhibitors of the cytochrome P450. Inducers reduce the effect of warfarin, and this includes chronic alcohol intake, anti-epileptics such as carbamazepine or phenytoin, antibiotics like rifampicin, whether he has any inhibitors of cytochrome P450, which increase warfarin, such as acute alcohol intake, anti-epileptics such as valproate, and antibiotics such as erythromycin and isoniazid. And also you want to check his INR when he starts or stops medications, vitamins, herbal medications, over-the-counter drugs. R stands for reduce his risk of bleeding, so you want him to avoid falls, have a safe environment at home, potentially ask for occupational therapy to come see and assess his home, wear gloves while gardening to prevent bleeding, soft bristled toothbrushes to prevent bleeding from his gums, waxy floss, and electric razor when shaving. In terms of foods, you want to recommend a normal balanced diet with some green vegetables, but it's important to not vary the amount of green vegetables taken, because this is a source of vitamin K, and if you suddenly increase your green vegetables one day and stop eating another day, this may lead to instability with your INR. You also want to counsel him on adverse reactions such as bleeding, skin necrosis. There's a 1% chance of intracranial bleeds, as well as peptic ulcer and bowel bleeds. And regular INR testing should be done every day until a therapeutic INR is achieved. He must do an INR at least once every 4 weeks, and more testing regularly if he's starting or stopping or having a short course of treatment. And organize more testing during traveling or a viral infection, for example gastroenteritis, where he has nausea and vomiting, and he may actually vomit out his warfarin dose, and so therefore his INR would decrease. So that's just a summary page of how you would counsel for warfarin. I hope this presentation was useful. Please let me know where I could improve and what additional topics you would like covered. Thank you. Bye.